Good evening. This is Dr. Bernstein with our October 2016 teleseminar. Our next two teleseminars for 2016 will be held on November 30th and on December 28th, both Wednesdays. Look forward to visiting you then. The usual warnings, an answer that I give to a question may not be correct. There's no way that I can get a complete history and physical examination pertinent to a given question. So I'm just guessing at the answer. The intention is that many listeners will benefit from the knowledge that this generates, and I may not properly answer the question of the individual who submitted it. The intention is to generate a lot of knowledge. That's it. We have a special subject today, which I'll read to you. New report to show your physician explaining the origin of the ADA's high-carb, high blood sugar, and high A1C guidelines. I repeatedly get questions, what do I show my physician as evidence that what he's telling me is wrong, that my blood sugar shouldn't be so high, that I should be eating less carbohydrate, that I shouldn't be restricting fat, all these things that you're telling me are correct. Where's the proof? Well, first of all, we have repeatedly given you an article published by members of the Nutrition and Metabolism Society. My name is number 2 on the author list. The article is out there on the internet. The title of the article is Dietary Carbohydrate Restriction as the First Approach in Diabetes Management. Critical Review and Evidence Base. This article was published in the journal Nutrition in January 2015, pages 1 through 13. So you could find this article on the internet, and it gives many, many references citing the importance of low carbohydrate diets and normal blood sugars. If you want to do literature searches on your own, you'll find many articles. However, this brand new article that just came out recently in the Journal of the American Medical Association sort of changes the picture in, how shall I put it, in a logistical sense. It points out that industry sources of high carbohydrate foods, especially sweet foods, Coca-Cola, Domino Sugar, and others, have been bribing organizations such as the ADA, and the ADA is specifically named amongst others, to put the blame for obesity in the USA on high fat rather than on high carbohydrate. And it lists, as I said, the many organizations that have been bribed, and it points out that the bribery has been continuous since 1967, and we see instances of it today with announcements that, just recently the ADA announced that snack food vendors are paying them a royalty for every snack food machine that they put in, that the ADA gets placed into schools. We know that the ADA received large sums of money from Domino Sugar for recommending a mixture of Domino cane sugar and stevia as the recommended sweetener for diabetics, etc., etc. So this whole ball game that's been going on since 1967 of high carbo, high blood sugars has really been brought about by bribery. Now, we know that organizations have been bribed. We don't know about the individuals within organizations, whether it's employees, professional officers, or whatever. We have no evidence, no statement in this article about that part of the ball game. Here is the copy of the article that will appear on our Dr. Bernstein University videos. Those of you listening only to the teleseminar will not see this, but they will have an article written about this study in Science Daily, which is attached to the announcement for this teleseminar. So what you show your doctor is either the Science Daily article or the JAMA article, and say, hey, you've been a patsy. You've been believing the con game that's been going on since 1967, that was paid for by bribery, and you're imposing this on me. What do you think your patients are going to think of you when they get the news of where your information came from? So that's basically it as far as our special subject goes. Now we're going to answer some questions. What is the best way to get rid of lipos on the lower abdomen belly fat? Well, I don't know what this person means by lipos, but I would assume that it's lipohypertrophy that is very common amongst people who use insulin pumps. And it's because the same site has been used over and over for the injection of insulin, and insulin is a growth hormone or fosters the growth of fat. So these people have what I call wings of fat around their abdomen, and the only answer to this that I know of, outside of plastic surgery, which I don't recommend, is years of injecting insulin at other sites than those that have blossomed with fat. There's another kind of damage caused by repeated injection of insulin in the same site called lipoatrophy, where you get dents in your skin. This is what I had when I was a kid, because I injected large amounts of insulin in my legs due to the very high carbohydrate diet I was put on. And the answer there is to inject human insulin into the dents that you find. This is nowadays very rare, so probably doesn't pose a problem. Next question. Regarding exercise and its effect on raising blood glucose, and how high it should get and how quickly it should come back down. For example, I awoke and tested at 5.4 millimoles per liter, which is a blood sugar of 106, and then did an intense 5-kilometer run, which raised it to 8.4 millimoles, about 151, so it raised blood sugar about 50%. This came down to 7 millimoles after 45 minutes. Now, if you're not diabetic, your blood sugar should not go up when you exercise in the morning. If you are diabetic, because of the dawn phenomenon and because your insulin level is being cleared by the liver early in the morning, your serum insulin level, you may not have enough insulin to control the counter-regulatory hormones that you produce when you exercise strenuously. So if you're following our regimen, we have tricks for preventing any blood sugar increase, and that's what we try to do. It's not appropriate to have a blood sugar increase if you're trying to normalize your blood sugars. So for those who take insulin, some people will inject a small amount of rapid-acting insulin before they go out and do their run, and they do this by trial and error. How much will it take? Well, one of my earliest patients was injecting 2 units of regular insulin before he ran. Another patient might only need a half a unit. Another patient might need something faster acting, like Humalog insulin, a half a unit or maybe 1 unit or whatever. But it's all trial and error. And then when you get to the dose that works, fine. Alternately, if you take Tresiba insulin twice a day, once at bedtime, the bedtime dose should hang over into the morning long enough to prevent the dawn phenomenon. But it's not a desirable thing for blood sugar to go up and then down. We want to do something to prevent it. Next question. Top endocrinologists in my state believe all diabetics over the age of 45 should be on statins. Is there a definitive study or two that I can show them to change their minds? Well, first of all, the reason for this statement, which stems from the ADA, is because of the ADA's desire that blood sugars always be elevated and that A1Cs always be elevated, and therefore that diabetics be at very high risk of heart disease. So if you can eliminate the risk, why should you give them statins? Again, you can take the articles that I cited earlier in this seminar and point them out to your doctor. If your blood sugars are normal around the clock, if you have an A1C in the 4s, you're probably at no greater risk than a non-diabetic. But if you've had years of high blood sugars and then you started to control them, you may have had deposits on your coronary arteries. And here you would want to get proper imaging studies that we've discussed in the past to see whether a statin could be of any value. But remember that even in high-risk individuals, it takes something like 48 5-year treatments. 48 patients had to be treated for 5 years to save 1 life. So it's not like they're high-grade lifesavers. So I'd suggest that you look at your blood sugars, you get the articles we talked about previously, and remember that this whole system of bribing the ADA to recommend high carbohydrate is also bribing them to recommend medications to treat the consequences of high carbohydrate. And you will see, I'm sure that the ADA is receiving very big advertising money from the manufacturers of statins and other drugs that are needed to treat the complications caused by high blood sugars. I have not been diagnosed as a diabetic, but my waking blood sugars are anywhere between 98 and 117. My blood sugars throughout the rest of the day are normal for a non-diabetic. I have lost 10 pounds, but have another 20 to go. I'm trying to eat better and carb count. What do you think? Well, I do not like carb count. That's the ADA ball game. The ADA ball game is eat a lot of carbohydrate, count how much, cover it with a lot of insulin, and get fat. And if you're not already diabetic, make yourself diabetic. This is not what I recommend. I would suggest that you read my book and follow the dietary guidelines that appear in the book. The chances are that you're eating too much carbohydrate, but we don't know that for sure. You may need medication. That's an uncertainty too. You may benefit from exercise, but the classic carb count, as advocated by the ADA, is, if anything, harmful because it fosters obesity. I am 20 years type 2, much uncontrolled, bad leg pain. Can I still help myself by strict carb restriction, or is it too late? My age is 72. Well, the leg pain could be caused by things unrelated to diabetes, could also be caused by diabetic neuropathy, could be caused by poor circulation, could even be caused by what's called iliotibial band syndrome, which is a complication of diabetes that involves glycation of collagen on the side of the leg just above the knee. So there are lots of causes of leg pain, and there's one other common possibility. If you're getting leg cramps, muscle cramps, you might be hypothyroid. So you should check your free T3 as a screening test. Now, if your leg pain is simple neuropathy, then it reverses over time with absolutely normal blood sugars. How long? It varies. But I've seen the pain resolve very, very rapidly in a matter of months. Usually, as the nerves heal, the pain gets greater temporarily and then disappears. There's also a syndrome that we see in diabetics where usually the upper leg is involved. It's called proximal neuropathy, and that could involve muscle damage. It could be very painful, and in addition to controlling blood sugars, this syndrome has been treated with intravenous gamma globulin. So the first job is to find out what's causing the leg pain. My fiancée is type 1 for 15 years, but has problems with gastroparesis. She has a hard time eating and digesting foods high in fats and most vegetables, like the dark greens. Do you have any suggestions how she can use your program with these challenges? Well, first of all, she should read my book, Dr. Bernstein's Diabetes Solution, which has a whole chapter on gastroparesis, and there are many tricks. The most effective trick is probably using liquid meals. So we use protein shakes and ground up meals and so on. The other thing is to look at the video in Dr. Bernstein's Diabetes University that deals with gastroparesis. Then there are several medications we use to treat gastroparesis. That sort of covers about all the bases, but gastroparesis is a very serious condition, can make blood sugar control impossible, and should be addressed very seriously and aggressively. And we tell you how to do it in my video and also in my book. Next question. What is the difference between your diet and the Atkins diet? Well, first of all, I suggest that you look at my book, Diabetes Solution. The main difference between my diet and Atkins is that Atkins was designed for weight loss, not for normalizing blood sugars, and he proposed that people go back to high carbohydrate after they lose a certain amount of weight. And I find this to be the opposite of what you want to do for weight loss, because you're going to gain it back right back if you go back to high carbo. And certainly you don't want to take a diabetic, put them on a low carbohydrate diet, have them lose 10 pounds, and then go back to a high carbohydrate diet. Now, why on earth did Atkins recommend such a thing in his later books? It was because he was so heavily criticized by the medical profession, again, because of the bribery that we cited earlier in this teleseminar. And it was harming his ability to earn a living. So instead of keeping people on what was a high-fat diet, he put them on it for a few months to lose weight, and then allowed them to go back to the high carbohydrate. That's not my ball game. While Tresiba and Toujeo are made of different molecules, these are two long-acting insulins, is one more efficacious or less harmful to the body than the other? Also, I think Tresiba lasts 52 days. That certainly makes it less expensive. Well, what he means by 52 days, I'm not certain. Maybe the manufacturer claims that you could keep it at room temperature for 52 days without it spoiling. I find that leaving insulin pens out in temperatures much above 72, 73 degrees Fahrenheit does cause them to deteriorate, so that they should be kept in the refrigerator. Now, Tresiba is a long-acting insulin that's new. It's a new molecule, different than prior ones. It is special in that it lasts overnight. It beats the dawn phenomenon. The manufacturer claims that it lasts for 42 hours, which only occurs if you take excessive doses. You could take a large dose of any insulin and make it last as long as you want by making the dose large enough. So you could take a fast-acting insulin like regular insulin and inject 70 units and have it last a week. But it'll be forcing the recipient to be eating constantly to offset the blood sugar reduction. Now, Tresiba in reality is a twice-a-day insulin for type 1 diabetics, might be a once-a-day insulin for type 2s who are making a lot of their own. The Toujeo is the same old Lantus insulin with its historic risk of possibly causing cancer, but it's in a super concentrated strength, 300 units per cc. This is designed, again, for people who are on very high carbohydrate diets and eating all day long, which again is part of the ADA guidelines, to give small injections to cover all that eating and all that carbohydrate. They make it extra concentrated. It also could be of value for very obese people who weigh 600 pounds, for example, so they don't have to inject a large shot. They're very insulin resistant because of their obesity. They may need large doses of insulin, so they would use the Trageo. But for people of near normal body weight, and even moderately obese people who are, let's say, 30%, 40% overweight, the Trageo serves no purpose, and it doesn't last as long as the Tresiba, and it still has the potential for causing cancer. So there's no place for it, really. We aggressively recommend Tresiba. Offhand, I don't even remember who makes it. I think it's Novo. I'm not on their payroll, and I'm lucky to be able to get samples to get patients started on it. Some of the foods that you suggest the diabetic stay away from are actually good for you. Like, let's see what it says. Like carrots. Do you recommend supplements to replace certain nutrients that you won't get if you cut carrots out of your diet? Well, we have a list in my book of something like 45 different vegetables that are low in carbohydrate. Why one would pick out carrots that are high in carbohydrate is beyond me. There are plenty of vegetables that have keratin in them, or vitamin B, B6, no, vitamin A. Carrots have vitamin A. So there are lots of vegetables with vitamin A. You don't have to have carrots. So just look at the list in the book. And I might add that most people following ADA guidelines are not eating anywhere near the amount or variety of vegetables that we recommend in the book. Most of them are eating things like pasta and bread, whole grain bread, pizza and things like that. I recently switched from Levemir split dose to Tresiba, which has really helped to eliminate the spikes I'd been experiencing at the tail end of each dose. I'd be grateful for your thoughts on whether there's a potential benefit to splitting the dose of Tresiba. Well, as I said before, that's the only way we use it, at least for type 1 diabetics. For type 2s who are making a lot of insulin, sometimes we get away with a dose of Tresiba in the morning to cover the daytime when they're challenging their beta cells more by eating meals, and then overnight they seem not to need any extra insulin. But for type 1s, it's always a split dose. You take it on a rising and at bedtime. Type 1 diabetic on an insulin pump utilizing Humalog U100, following your book. Well, can't be following my book because I strongly recommend against insulin pumps because we've never seen a well-controlled diabetic on an insulin pump, no matter what their diet was, at least if they've been on it for more than 5 years. because they cause scar tissue to form that makes the absorption of insulin unpredictable. So this person is not following my recommendations. Currently on 5 different basal rates over 24 hours. Blood sugars normalized around 85 milligrams per deciliter. I find that very hard to believe with an insulin pump. Should my basal rates on the pump be changed, or should I be taken off the pump altogether? Well, if you really are running a constant 85 milligram per deciliter blood sugar, which I don't believe, you could stay on the pump for maybe a year or 2 before you develop the scar tissue. But sooner or later, it's mandatory that you get off it because blood sugars will be unpredictable. Why is Humulin insulin, that's a brand for 3 insulins made by Eli Lilly, and maybe others as well noted, not to be used in insulin pumps? Well, this person is confused between types of insulin and brand name. He's thinking, or he or she is thinking, of Humulin R, which would be regular insulin, versus Humalog, which is a more rapid-acting insulin. Now, I generally recommend the regular insulin and no pumps because regular insulin is less potent than Humalog and therefore can be measured more precisely. The reason the pump makers like Humalog is because it works more rapidly, and they like to assume, the insulin pump assumes a lot of things that are false. It assumes that insulin works instantaneously, that there's no delay in it starting, and that it does all its job all at once. It assumes that you only need insulin to cover dietary, to cover food if you're eating carbohydrate, that you don't need insulin to cover protein, which is absolutely false. So it's pretending. They give you formulas, and they say, you follow our formulas, you'll have normal blood sugars, and the formulas assume that insulin works instantly, they only have to cover carbohydrate, and none of this works. But because Humalog is faster than regular, it's closer to instantly. Not very much closer. A regular starts in maybe 45 minutes. Humalog starts in about 20 minutes. Regular may last a total of 10 hours. Humalog at the tail end may last about 8 hours. So it's faster, but certainly not instantaneous. It's part of a myth. And again, if you're injecting it with a syringe, very hard to measure because it's so potent. It's double the potency of regular. So where 1 unit of regular lowers me by 60, quarter of a unit lowers me 15, 1 unit of Humalog lowers me 120, and a quarter of a unit lowers me 30, it's impossible for me to fine-tune my blood sugars if I were to use Humalog. Next question. I started following a low-carb diet in April 2016. I still have some adjustments to do with insulin timing, but overall have done fairly well getting better control of my blood sugars. I was eating 60 to 100 grams of carb before, and my A1C was 6.4%, which is an average blood sugar of about 156. Now I eat 30 grams a day, and my A1C came down to 5.7, which is about 128 milligrams per deciliter. However, over the past 2 months, I've gained 10 pounds. I do not eat many nuts and am only eating 1,200 to 1,500 kilocalories today, but continue to gain. What is causing this, and how can I stop or reverse it? Well, I can see several things that you're doing that are wrong. And you're not really following my low-carb diet. First of all, you're eating nuts. And nuts contain carbohydrate. And some nuts are very high in carbohydrate, like cashew nuts. And the amount that you're eating is apparently variable. So that's going to have a potential for weight gain. Then you're eating between 1,200 and 1,500 calories a day. You're not on a constant meal plan. So things are varying, and your insulin doses have to be varying, and you really don't know how much insulin you need each day because you're varying the food that you're eating each day. So you have to go to a constant meal plan. There's the matter of overeating, taking unpredictable amounts of insulin. You don't know how much excess insulin you're taking because you're varying what you eat. You have nuts. Then there's one other thing. You should check your free T3 because you may be hypothyroid. And sometimes people who are on low-carb diets may reduce their free T3 levels, so that should be studied. I suggest strongly that you read my book and do what it says so that you're really on my diet. What would you say is the better treatment for my diabetes? I've been taking Novomix 3070 for 19 years, and my A1C is 6.3%. That's an average blood sugar of 152. But have recently lost the toe due to infection, and the diabetic educator is suggesting I change to Lantus at night and Nova Rapid, which is over 8 millimoles, and my GP doesn't agree because he says I'm doing well on the Novomix. Well, with an average blood sugar of 152, which is about double normal, I could understand why you lost the toe. You're much more likely to have infections that don't heal. On top of that, with an average of 152, you're in reality going much higher and much lower. So you're on very erratic blood sugars that can cause further problems. What I'd suggest that you do is read my book, Diabetes Solution, which would be recommending totally different insulins than any of those that you're considering. The 3070 mixture is an old attempt to do something that never worked. There was a myth that if you took NPH insulin and added 30% regular insulin to it, the regular insulin would act separately. So you could take it in the morning and the regular would cover your breakfast while the NPH covered the rest of the day. Well, NPH doesn't last a day. The regular really doesn't work separately from the NPH. It just speeds up its action. And the NPH slows down the action of the regular. So you end up with a mixture that's useless. Read the book, Diabetes Solution. I have twice gone on the Atkins diet. The first time I've jaundiced in 9 days. The second time in 5. This diet seems very similar to Atkins. Is there anything I can do in order not to have liver pain and turn yellow? Well, I'll make a guess. My guess is that you may have gallstones. And if you're on a high-fat diet, the gallbladder is going to secrete a lot of bile, and that can force a stone into the bile duct, blocking the exit, and that leads to a backup of bile that can get into your bloodstream and cause jaundice. So I think it's the high fat. And you really should have your gallbladder examined, and you may or may not need surgery. I don't know if it's possible to do any surgery nowadays that just removes gallstones. I think what they usually do is take out the whole gallbladder, but I'm not certain of this, and you could double check. But the diet caused it because the fat causes secretion of bile. People without gallstones don't have a problem. How much effect will cortisone have on blood sugar, and how long will that remain in my system? My doctor is recommending it for inflammation of my muscles. Well, it depends on the dose of cortisone. It depends on whether it's injected, where it's injected, whether you're taking it in the form of prednisone as a pill, and so on. Years ago, I'm talking maybe 60 years ago, I had diabetic frozen shoulder. There was no such diagnosis in existence at the time. No one knew the treatment. Doctors gave it strange names and told me I had bursitis, injected it with cortisone that relieved it for a few months, and the pain came back much worse, but my blood sugars were elevated for about a month after the injection. And this happens with my patients too who get cortisone injections. So, first of all, if your muscle pain is caused by a statin drug, I would suggest that you stop the statin and work up your atherosclerosis with imaging to see if you really can benefit from a statin. And that's the most common cause of muscle pain. Another cause would be low thyroid. So if you're hypothyroid, that can cause muscle pain, especially muscle cramps. So you should check your free T3 as a screening test. And I've found many people with chronic muscle pain benefiting from a concoction that I devised, which is a mixture of lavender oil and 10 parts of DMSO. We put it in a roller bottle and we roll it on the skin over the region of pain. It also works for arthritis. Within 4 minutes or so, the pain goes away, and it works for several hours, and then you may have to put it on later on. The lavender oil can be irritating to the skin, and that's why we dilute it. One of the reasons we dilute it with DMSO. Compounding chemists can make this up. If you find that your skin itches after the treatment, the chemist should use more DMSO. Instead of being 10 to 1, you could be 15 or 20 to 1. But this is quite remarkable in relieving muscle pain. And for some people, it's relieved the pain for months and even cured it. Next question. I've just been switched to Levemir from NPH. I noted in one of your terrific Diabetes University sessions that you recommend Levemir be stored in the fridge. I only have access to pen fill or the pre-filled pens, no vials. Is it okay to put the pen and the current pre-vial in the fridge, or should I take the small vial out each time? No, you can put the whole pen in the refrigerator, and I would suggest that you put all of your cartridges in the refrigerator when they arrive. That's basically it. If you're a large person and taking large doses of Levemir, so that a cartridge is used up in only 10 or 12 days, you could keep it at a room temperature. You don't even have to put it in the refrigerator for those 10 or 12 days. But room temperature would be up to about 73 degrees Fahrenheit. Is Victoza still your preferred incretin mimetic? Have you had any adverse reactions to it since your book was published? Have you found any of the newer diabetes drugs to be helpful? Well, we really focus incretin mimetics on certain times of the day in order to control overeating. I don't use them to lower blood sugar because their effects directly upon blood sugar are trivial, like published results lower A1C 0.3%, which is something like 12 milligrams per deciliter on average blood sugar. So it depends on the time of the day that you're overeating. That's why we may use Victoza, we may use Byetta, and we may use Symlin, depending upon the timing situation. Victoza is the longest acting of the three. I might use that for a patient who stays up late, starts snacking after dinner and continues snacking until bedtime. We need something relatively long-acting, so you might take the Victoza before dinner. It'll start working after you finish dinner and might last until bedtime. The others are more rapid. My husband is 52 and has elevated blood sugar. A1C was 5.8 in January 2016. I'm a type 1 and have been following your advice and have had great results. A1C went from 9.1 to 6.0, which is still elevated. It's an average blood sugar of 140. Since I had such a good result with changing my food choices, I suggest that he follow your plan. He did for 2 months, lost 16 pounds, but his cholesterol went from 179 to 273 and his A1C increased to 5.9. We are perplexed. Okay, does this diet not work for certain people? Well, first of all, in your note you say, you're following my advice. I would say that you should follow my book, Diabetes Solution. If you had been following it, you would not have been happy with an A1C of 6.0. And you would have learned all the tricks, eating-wise, medication-wise, etc., that we discuss. So, number one, use the book. I don't know exactly what happened, but I do know that if you gained weight, your A1C is likely to go up. I also know that different labs may have different values of A1C from the same tube of blood. There are different kits and different protocols used by different clinical laboratories. I find, as a rule, that hospital-based laboratories are not as accurate as the large commercial laboratories, and that there's considerable variation between one hospital laboratory and another, and also between two specimens at a single hospital laboratory. Okay, next question. Dex-4 glucose tablets versus liquid. A good question. Using glucose tablets is much more convenient than using a liquid to treat a low blood sugar. The tablets work adequately rapidly enough for people who do not have gastroparesis. There are situations, however, even in a person without gastroparesis, where the liquid glucose would be mandatory. For example, if you're running a marathon or engaged in some kind of sports competition, or you need more rapid action. Now, there are some people who absolutely need the liquid glucose. For example, those with significant gastroparesis. And that can be determined by your physician if he does an RR interval study. And you can search for my name and RR interval study on the internet, and you'll see a protocol for how your doctor can do this. There was an article in the journal, I believe, Diabetes Care. There are other situations. For example, if I'm sitting here all day working with patients and I see that my blood sugar is on the low side, I don't want to be slow in my thinking, seem confused, etc. If my blood sugar is on the low side and I'm with a patient or talking to a patient on the telephone, I want to correct it rapidly. So I'll use the liquid. If I'm going to be driving a car and my blood sugar is low, I don't want to delay getting into the car for an hour. I'll use the liquid glucose to make it work faster. So it really depends on the situation, and it depends on your situation. These examples are typical. The one thing about the tablets is that for many people they have to be cut into quarters. They're already pre-scored so that you can hit them with a knife and cut them in half, but for smaller people like me, you have to cut them into quarters, and each quarter is 1 gram of glucose. On the liquid, 1 teaspoon is 1 gram of glucose. I take 6 units of Tresiba at 9 p.m. You give twice a day. Would you recommend splitting the dose in half and giving in the morning and before bed? Well, first of all, I don't know if you're a type 1 or a type 2 diabetic. And secondly, I don't know what your blood sugars are. The one governing rule is what happens to your blood sugars. If 6 units of Tresiba at bedtime is all that you need in the way of insulin, and your blood sugars are all running around 83 and barely changing, then it's working. If, on the other hand, if you don't eat for a day as a test experiment, and your blood sugar goes up during the day, it means you need placebo during the day, during waking hours. In that case, I might split it in half and take it at bedtime and on arising, but you might, because it's spread out so long in its action, you might have to raise the dose. But you start by splitting in half, and then if you need more, after a few days, you increase the dose. Next question, is there any danger of blood sugar crashing as a result of anesthesia during surgery? When I showed up with my blood sugar at 82, they insisted on giving me a sugar solution intravenously. When I woke up, my blood sugar was 189. The likelihood of going down from surgery is virtually nil. Sure, if you took too much insulin, too much basal insulin in the morning before the surgery, you might go down. That's not a message that you should not take basal insulin. You must have basal insulin. More likely, the stress of surgery will raise blood sugar. Now, most hospitals are not considerate of a patient's blood sugar during surgery or even at any time while in the hospital. I had a brief outpatient hospitalization a couple of years ago where they would have killed me 5 times if I had not intervened each time. And when I pointed this out to the president of the hospital, he said, "Don't worry about this, it's not your business." So, I was thinking about future patients. A copy of this article, which shows what can happen during surgery, appears in the Journal of the American Medical Association. You can write this down. Journal of the American Medical Association Internal Medicine, January 2014. The title is "More Can Be Life-Threatening." It's interesting that the editors of the journal wrote the title, which was different than mine, and indeed what they did was life-threatening. More would have just been more life-threatening. But you can find this thing on the internet if you can get hold of it. This article will be attached to the Diabetes University copy of this question. What is a good blood glucose level before going to bed in a 9-year-old girl diagnosed a month with type 1? I am always scared she will have hypos at night, but don't want to feed her carbs before bed. Well, first of all, I'd say that you get a Dexcom continuous blood sugar monitor. Get the latest version, and you can remotely see her blood sugars on your iPhone, even if you're in another room. Not only that, you can get alarms on your iPhone that can wake you up by noise or vibration or both if her blood sugar drops below a target that you set. So you do have a backup and don't have to deliberately force her blood sugar to be high. Now, kids run, 9-year-old kids run in the 70s if they're not diabetic. So I would say that if you set a target of about 80 or 85, you'd probably be pretty safe. You might get some false alarms that would wake you up prematurely. But I also urge you to look at the Type 1 GRIT, G-R-I-T, website, because the people who blog on that site help one another. They give each other advice. They run into the same problems that you encounter. I also urge you to get my book, Diabetes Solution, because without it, you're going to have wild blood sugar swings. And even with the help of a continuous glucose monitor, you're going to be going crazy with the blood sugar swings. My book is geared to preventing that. Okay. That's it for tonight's teleseminar. Our next 2 teleseminars will be November 30th and December 28th, 2016, both on Wednesdays. Thanks for listening, and I look forward to being with you again in about a month.